Welcome everyone back to our 8th master class. And this is directed by Dr. Stephen Farrow, who is a professor of medicine, endocrinology, and innovation at the William Carey University College of Osteopathic Medicine. And Dr. Farrow is also the former executive director for the National Diabetes and Obesity Research Institute. He treats and researches diabetes, hypertension, and obesity, and metabolic disease in the laboratory, the community, and with pharmaceutical sponsors. He is a member or advisor to several Mississippi health promotion and advocacy organizations, including the Mississippi State Department of Health, the Mississippi Public Health Institute, the American Diabetes Association, and the Amputation Prevention Alliance. His noteworthy accomplishments have been recognized by the VA Secretary's Hero Award, the American Association for Clinical Endocrinology's International Endocrinology Service Promotion Award. That is a mouthful. And the Mississippi State Health Department's Pioneer and Public Health Institute's President's Circle Award. Congratulations to you. Approximately 20% of the variance in population health outcomes can be explained by access to and quality of clinical care, and that's what you're going to talk to us about today. This master class discusses the causes of obesity and diabetes. It examines their relationships with one another and explains their widespread harm to multiple systems, not only personal, but also social and economic. Dr. Farrow will also share some good news with us today about the positive impact of lifestyle change. No matter how small that change, it makes a difference, doesn't it?
It does.
And he will describe the roles of monitoring, medication, and surgery in managing disease. So, Dr. Farrow, it's yours.
Thank you.
Take it away.
Laura, I greatly appreciate this and great to have an opportunity to talk to the group there. To start out, we usually like to explain any disclosures so you know there are no conflicts of interest. I do serve as a consultant for a couple of pharmaceutical corporations that we do clinical trials research for. This clinical trials research is important because if I'm going to prescribe a medication for you, I would like to have some idea that it actually works for your population. So it's not the concept of using folks as guinea pigs, but rather to make sure that the medications that are available are safe and effective. So you'll hear this come up again later in the talk, but just explain that. Then, in addition, just to be fair to our numerous content developers, there have been some photographs included in this presentation whose authorship I have not been able to confirm. But because we're using this for an educational purpose, we thought it would be an enhancement to your learning, and we appreciate their generosity in having regulations that allow us to do that. Today, by the end of this course, we would like for you, the audience, to understand how diabetes and obesity are related, what causes them, and what harms they cause, the roles of monitoring, medication, and surgery in managing diabetes, and as you mentioned, how lifestyle change can help.
Right.
So we love examinations to test our knowledge. So to start out, we'd like to take a couple of minutes, not even need that long because they're very smart.
Right.
And we'll run through a few questions. These are multiple choice, and I will read them, but of course you'll be able to view them as well. Question number 1. And by the way, we'll go over the answers at the end of the talk. So you'll have a chance to check your answers as we go through the material. First question, what is diabetes? A, diabetes is too much insulin. B, diabetes is too much sugar. Or C, diabetes is high blood pressure. Question 2, why is diabetes dangerous? A, because it's contagious. B, because there's so much energy that it is difficult to sit quietly and rest. Or C, because it damages body parts, brain and eye, heart, kidney, liver, legs, and feet. Question C, why is it so difficult to prevent diabetes? A, because children eat too many vegetables and not enough sweets. B,
That might be a giveaway. You're going to need to keep a straight face with that one.
but you never know.
This is why you test in advance, right?
Yes, indeed.
Right.
B, obesity is increasing across the country, so insulin doesn't work as well. Or C, more people are joining gyms and too much exercise increases sugar. And question number 4, what are 3 lifestyle ways I can prevent or control obesity and diabetes? First, eat fresh produce for better sugar levels, exercise the muscles because insulin works better, restful sleep, which lowers stress hormones. That's choice A. Choice B is stay awake at night, better sugar levels, avoid toothbrushing, insulin works better, and play video games, lower stress hormones. Then your final choice is watch action movies, better sugar levels, smoke cigarettes, insulin works better, and drink beer, lower stress levels. So we'll come back to those. What is diabetes? In diabetes, the body's sugar levels are too high. Either the body does not make enough insulin, starting in childhood, they've never made enough, or you got injured somehow, or the insulin that you do have doesn't work as well. This is considered insulin resistance and is commonly found in obesity, pregnancy medications, some effects of some medications, and endocrine disorders. Notice that when we first started talking about this slide, we said the body's sugar levels.
Right.
We didn't say blood sugar levels.
No, you didn't.
Yes.
You must be planning to make a point about that.
Yes. Blood sugar is important because that's what we traditionally have been following for the past 50 some years in order to determine whether your body is exposed to toxic levels of sugar. Before we had access to blood sugar and knew how to test that, we actually tested urine.
Right.
So a couple of interesting things. In terms of the urine, diabetes is called diabetes mellitus because the definition of the Latin terminology is sweet urine. I imagine somebody at some point tasted the urine and said, oh, you have diabetes and this is what the urine tastes like. We didn't do that as medical, so I wouldn't agree. So then, as science went on, we were able to test the blood. Right. We actually found out that you can measure circulating levels of sugar in the blood very quickly with a glucometer, which most of you are probably familiar with. And then the current technology, which we absolutely love, is a continuous glucose monitor. Put it on your body. Every 5 minutes, a value goes to your phone. So if you want to know the impact of your breakfast, you can find out 1 or 2 hours later. If you want to find out the effect of swimming 100 yards, you can tell that before and after. It is an absolutely wonderful and game-changing device. And anybody at risk for diabetes, prediabetes, and obesity should think about having access to one. The other point that I wanted to make about this slide, remember we mentioned that diabetes was initially diagnosed by testing the urine for sugar. So I'm hitting myself in the head. 60 some years later, after that technology was developed, we suddenly realized that if your body has too much sugar, why don't you just get rid of it in the urine? Don't try to stop it. So there is a class of medications called STLT antagonists, and they are designed to prevent your body from reabsorbing sugar. That is now a mechanism to manage diabetes, whereas before we were very concerned about seeing sugar in the urine. Now we don't worry about it. The more we can get rid of, the better.
And you know, the interesting thing is your body will store as much extra energy. There's not a cutoff. There's not a cutoff valve somewhere to limit the amount of extra fat that our body will store.
Absolutely. So what do you see when you get diabetes? The cartoon there shows pretty much have to run to the bathroom frequently. You're very thirsty often. You may lose weight because remember, your body has difficulty exercising or hanging on to the sugar. In the case where your insulin isn't working as well as it should, you'll find that you're more hungry. You get tired a lot. Again, the sugar is designed to help you do work. And if it's not getting to the places where it needs to be, there you go. Your vision may become blurry and you may have difficulty healing some wounds. And ultimately, you may have heard people talk about neuropathy, which some of our older patients with diabetes, it's excruciating for them. It's the sensation of pins and needles or worse in the tips of your fingers, in your feet, and other parts of your body. And that we believe is related to toxicity of the sugar and damaging some of the nerves that support those areas.
Again, so many body systems it's not just the fact that you have, quote, high blood sugar,
No.
right? So your entire body and the systems of your body are impacted.
Yes, absolutely. Unfortunately, that's why medication and lifestyle are so important. By doing things in the case of lifestyle that help promote a healthy lifestyle, you can have a major improvement and impact on your blood sugar levels. In the case of medications, we're lucky as science has advanced to be able to target those medications more towards specific issues of insulin resistance, as opposed to the broad-based medications that we had in the past that had a lot of adverse impacts that we really didn't want, but we couldn't do any better. So science is wonderful as it advances. So why is diabetes dangerous? We talked about inflammation, or actually we did. What is inflammation? We'll get into the details in a minute, but inflammation can actually irritate the linings of your blood vessels, make it difficult for blood to circulate, so it can't get to areas that need it, like the heart and like the brain. So inflammation can predispose you to strokes and heart attacks. Infections may be harder to treat because with the high sugar levels, bacteria love that, and your body has difficult preventing infection and fighting infection in a very high sugar environment.
What happens in your mouth when you have diabetes? And that sounds like that could be a whole maybe separate, conversation. But, I think about the mouth and, it's so easy to, maybe with your dental floss or dental tape, injure your gum, or, people have poor dentition. Maybe their teeth are not in good repair, and so they have infection. How does that work with diabetes?
As we're speaking here, we have a ton of different types of bacteria in our mouth. They're just there. For good or bad, they're there and they're balanced.
Do you know, I heard there was a dental journal article that said there were more than 200 different bacteria that lived in the mouth. 200. And I thought to myself, I've had a couple of courses in microbiology, but I know I can't even name 200 different bacteria. That's mind-boggling.
Absolutely.
And they're in your mouth and my mouth.
Yes.
And if my teeth are not in good repair, my gums are not in good repair, that's trouble when I have diabetes.
It very well can be. This is a burgeoning field. We're learning a lot about it. It's almost unquestionable that a lot of those bacteria actually serve a good purpose. Or maybe there are some good bacteria that balance out the bad bacteria. But as you mentioned, if you don't have good oral hygiene, for example, you have a diet that's relatively high in refined sugar,
right,
and you don't brush your teeth, and you get a cavity, okay, then that's a little area where the bacteria can start to concentrate to grow at abnormal levels.
Right.
And they can actually spread to other areas of your mouth or go into your bloodstream, circulate and get down to the heart, cause a heart infection called endocarditis, or go to the brain or other parts and cause those problems. So that's an issue.
It's a direct line into the sinuses, isn't it, from your mouth?
Oh, yes, absolutely. Yep. So same place there. In addition, your gums are at risk. So illness called gingivitis can develop when the bacteria have an abnormally high presence and you haven't taken good care of your gums, or they become injured for some reason. Maybe you did floss a little bit too hard and you've got a cut there. Well, if those bacteria are allowed to grow, then your gums can actually become inflamed. Your gums are critical to keeping your teeth firmly and appropriately aligned. Wow. You destroyed that alignment, then your teeth may actually be lost.
Right.
Some people say, well, okay, it's inconvenient, but my teeth hurt. I'd love to have them pulled. Well, just think about the impact on your diet, not to mention your appearance, if you lose all your teeth.
Right.
This is a real problem for us as physicians, because if I want to use a healthy diet of fresh produce as part of your management, then I find out that you're unable to chew celery or lettuce.
Right.
That really handicaps what we're able to do.
It hurts your employment opportunities. I have a colleague at the University of Florida who was actually going through and trying to determine the monetary value of different teeth.
No kidding.
Based upon the position of where they were. And certainly those in the front, upper front, where, yes, when I speak and smile. So your employment opportunities are hurt and cut dramatically.
Yes. And by the time people realize that that's an issue, sometimes it's too late.
Right.
And the damage has been done, and you have to go through very expensive restorations if you have the resources to do that. And those aren't simple.
No, they're not. And dentures don't always fit well. As you age, your gums, change shape. They become smaller. So my profession as a registered dietitian, nutritionist, again, so concerned about the condition of the mouth because thinking that where these teeth bother me, and my grandmother and my parents, they got rid of their teeth and I can't wait until I get rid of mine is not the best forward thinking approach with managing your health.
Absolutely. So I guess we could say here, a key lifestyle component would be good oral hygiene.
Absolutely.
In yourself, your children, your friends, let everybody know. Because if that's well managed, then that's one thing less that we have to worry about in terms of being able to manage your metabolism. Just to list a few other issues, we talked about stroke and heart attack. We talked about infections, which can take the form of ulcers or gangrene. And if they're bad enough, you may even have to have a limb removed because the ulcer cannot heal and the chances of spreading to the rest of your body and causing injury or death are great. And then we talked about liver. We did talk about blindness very briefly. Blindness in diabetes is a very high risk outcome. So it's important for individuals to have eye evaluations at least twice a year. And if there are findings of any sort of retinopathy, that's a common term for diabetic eye disease, that they be managed in concert with an ophthalmologist. Please don't take it for granted. Don't skip your eye appointment because we have no mechanism for restoring vision at this point.
I have a question for you. I understand that about 25% of people with diabetes in the U.S. don't know that they are living with diabetes. And I'm wondering if, for example, we go for an eye exam, would it be possible for their ophthalmologist or optometrist to, in the process of conducting their eye exam, identify or find signs of diabetes?
Funny you should mention that. So during the introduction, you mentioned my work at William Carey University. There's also another university up in Detroit that I work with. There are devices that allow you to take an image of the back of the eye for anybody and actually transmit those images to an ophthalmologist in near real time and actually determine what your risk of diabetic retinopathy is. We actually use that as a screening tool in some of the church community outreach that we've done. The technology has since improved to the point where using artificial intelligence, you can actually get the computer to give you a near instant reading of the probability of eye disease.
Oh, wow.
So yes, when you have the resources and the time, eye screening is a very good adjunct to blood pressure measurement and blood sugar checks and hemoglobin A1C checks to determine one's risk for eye disease. I'm actually working with another colleague at Mississippi University to try and identify a chemical in the urine, just give a urine sample, that will tell you that you have probability of developing kidney disease even before your kidney starts to malfunction. So that's a new research project, and we're very excited about that.
That would be wonderful.
Yes. And we kind of talked about all these risks. A picture is worth 1,000 words. I do want to highlight the gentleman in the wheelchair who's a patient of a colleague of mine up in Mississippi Delta, Dr. Faluso Fakaridi. He's been in Mississippi for about 14 years. He's an interventional cardiologist, and he's made great strides in trying to restore circulation in patients who often have diabetes but have peripheral vascular disease and are at risk for ulcers, gangrene, and amputations. He's had tremendous success in reducing the amputation rates up in the Mississippi Delta. So proud to have him as a colleague.
I look at that picture, and I told you that picture impacted me personally when I looked at it, because I saw a young, healthy man in a wheelchair without one of his lower portion of his leg. That must have been a life-altering surgery.
Quality of life. Well, not to mention the extreme nature of the surgery. And if you notice, he's got a prosthetic attachment appliance on his right leg to fit his prosthesis on, which frequently in old technology weighed much more than the limb that you had before. Quality of life, employment opportunities, ability to manage and continue to contribute to the growth and development of any children that he might have. Sure. Because now he's actually limited in the activity that he can engage. And sometimes in cases which may be more extreme than this relatively young gentleman, the children actually end up becoming the caregivers at very young ages in order to support the relative who's lost.
Mm-hmm.
So for 1,001 different reasons, you absolutely want to avoid that. And the key to that is managing or preventing diabetes and obesity together.
Well, I'm wondering with regard to our feet and our hands, because you mentioned neuropathy, are there any kinds of self-exams or checks that we can do with regard to checking fingers or checking feet, checking between our toes that could help us identify problems before they get started?
You mentioned that there's a population of patients who may have diabetes and not be aware of it.
Mm-hmm.
So that creates a little bit of a difficulty. I would like for those individuals to do regular foot inspections, hands and feet,
Mm-hmm.
to see whether or not there might be sores that they don't feel, haven't
Okay.
detected, and may not be healing, so that they'll can actually be intervened with. If you let a wound don't go for several days and the bacteria have a chance to grow and spread,
Right.
it becomes much more difficult to treat. So inspecting your hands and feet on a regular basis is good advice for anybody.
Mm-hmm.
If you have limited flexibility, you can actually use a mirror and look at the bottoms of your feet. You really want to do that. If you have prediabetes or diabetes, or if you have obesity and you might be at risk for diabetes, be very careful trimming your toenails and fingernails,
Mm-hmm.
because if they happen to be cut and you're not aware of the injury, and again, you've gone for several days with this infection, then your body is put at tremendous risk. So we try to ensure that our patients who have diabetes have a good relationship with a podiatrist so they can go and get their nails professionally taken care of.
Is that better to go to a podiatrist than a nail salon?
This is not official medical advice. Several of my patients suggest that because of the very high demand for access to podiatrists and because of their fear of injuring themselves
Mm-hmm.
to
Right.
personal nail care, they will go to a professional and they will take their own tools so that they know that those tools are only used for them and they're
Mhm.
convinced of the hygiene.
Hmm.
Now, remember, it's not the job, it's not the task for these nail experts to provide this service. They're basically, what's the word? Cosmetic? There's no word.
Esthetician. Right.
Yes. However, there are people who are experienced, and if you feel that an individual might be able to help you with this challenge, then that's what my patients have
Mhm.
suggested that they've done. They take their own tools and they go to a person who's proven experience.
Right. Seems like a very reasonable approach. Yeah.
Very interesting. Reminds me of barbers in the old days who used to work as surgeons.
The barber surgeon. Where did the hole come from?
Absolutely. So you're asking about the pole. The blood, the bandages, the red bandages, the blue bandages, and the white bandages all around the pole. So, exactly.
Hence the barber pole with the red and white. Right.
Yes.
I wonder how many people know that piece of trivia.
But they all know it now.
Well, they're doomed now. They'll be set for Jeopardy.
Yes, indeed. So we're talking about the extent of this problem. This is it's an international problem. You are not alone. So there's no guilt assigned to this. We just recognize that there's a challenge. Let's make the best of it. Let's fix it if we can. In Mississippi in particular, diabetes costs somewhere around $3 billion a year.
In Mississippi alone? Oh, my goodness.
Now,
They're a small state.
Right. Now, this includes funds expended for care and adverse economic consequences of people having illnesses and perhaps not being able to go to work or other challenges that are not directly related to the medications and complications of diabetes, but the societal fallout, which is why I want myself to be healthy. I want my family to be healthy, but I also want my community to be healthy. Yes. Right. So 300,000 in Mississippi roughly have known diabetes. Roughly 75,000 have diabetes and don't know it. And another 814,000 have prediabetes. So these numbers have continued to increase. That 814 has gone up to 892,000 in 2024. And the numbers continue to increase both in Mississippi and nationally. So 17% of our population right now. But remember, we're concerned about diabetes and obesity as related metabolic disorders. we haven't really talked about the impact of obesity and why it leads to diabetes yet, but we're going to get into that in a minute. Meanwhile, what I do want to say is that way back in 1990, almost nobody had obesity. Nobody. So why would that be? Did our bodies evolve that quickly so that we've now become
computers? That's when we started having widespread use of personal computers and, game systems, and kids weren't outside running and playing, and
they're not out in the garden. They're not growing food.
Right.
They are not out on the baseball diamond or on the playground running around. They may not be swimming at the beach.
Right.
But we've got a lifestyle that's increasingly sedentary, less blue collar, if you will, in the sense, more white collar. But it's more of an intellectual or service type of society that we've developed as opposed to physical labor. We've progressively evolved in that direction in this country and, in fact, globally. So I like to kind of characterize this, and this is not exactly, but it will help you understand. In the 18th century, folks talked about supper a lot. Okay, supper and dinner occur at the same time. And I was always confused why some patients would talk to me about supper and some would talk about dinner. Well, it turns out that if you worked in an agricultural society, you'd eat breakfast. Your biggest meal would be lunch when you came back in and had something to eat so that you could go back and finish out the day. By the time you were finished with your work, you were so exhausted that you would basically have something very convenient, soup.
Right.
So you would have supper. But as we've evolved beyond that type of society, now people are used to having dinner, which is frequently the largest meal of the day. It's a large sit-down affair, very complex. But at least they would eat together.
Right.
So this is in the 19th and 20th centuries. Well, today, you're lucky if you see your kids or your parent, grabbing something out of the refrigerator before they take off, because we're so busy with so many different types of activities. That lost opportunity for a family dinner at a minimum not only increases the likelihood that you're going to develop obesity and diabetes just statistically, but it does it, I think, for a couple of reasons. First, instead of interspersing your consumption of food with conversation, you're just focused on the eating, number one. Number two, there may be certain stressors in your life that predispose to comfort eating. Well, if you have a chance to talk with a positive, supportive family, those stressors may be identified and you'll be able to find a strong solution to those, as opposed to subconsciously going to food, which certainly provides comfort, but may not be your best choice. So 18th century, we're on the farm. 19th and 20th centuries, at least we have family dinners, but 21st century, we're pretty much on the go. And I don't blame computers for that, 'cause I've got a computer here. But it does change the way you operate, changes society. So 1990, 10% of the population, maybe obese. Now we see the New York Times article in the middle of this section, published late last year. 3/4 of U.S. adults are overweight or obese. And if you compare the map from 1990 to 2030, you will see that the vast majority of the states have a significant obesity problem. Now, just for what it's worth, remember that we believe that diabetes and obesity are related, and that a solution for one may also be a solution for the other. Look down in the lower left corner of this slide. You will see what's commonly referred to as the diabetes belt. It's generally the southeastern United States, but that's also regarded as the stroke belt and the hypertension belt, pretty much any other chronic progressive disease that might be related to diabetes or obesity.
And that's why actually this masterclass series is so important, because we are addressing the southeastern part of the United States, the southeast region. And so recognizing that the prevalence of those chronic diseases is so much higher here in the southeast, it's a puzzle. I mean, it's really a puzzle to me. It's a frustration.
Yes. But as you mentioned earlier, knowledge and lifestyle can have a massive impact.
Right.
So we're not disparaging the culture here at all.
Not at all.
But if you understand what things can actually help improve your metabolism, and you're aware and you can actually implement those, you may be able to protect yourself, your family, and community from very serious adverse outcomes.
The key would be to establish healthier habits, right? From the beginning.
Yes.
And so, if we go back to your discussion about the family dinner table, the family dinner table was a place where you learned to eat foods that were unfamiliar because social imitation. You saw other family members eating these foods.
Sure.
Now that could work in reverse. Okay. Maybe you have family members that don't eat many foods. So you learn bad habits. But again, there's just so much support and positive education.
Yes.
At least there's the opportunity for it.
Yes.
Sitting around a dinner table with another group of people.
Sure.
That you don't receive that same benefit if it's just grazing go,
No.
right?
No. Plus, there's an individuals who generally has the duty to prepare the food.
Right.
And so they can make that choice and help ensure that you're exposed to more positive, healthful items as well.
Right.
Yeah. All right. So we're going to have some fun with this one. What is obesity? Hint. Although it may be more healthful to have weight that matches your height, and it generally is, obesity is not simply being big or small. It's a key take-home message. And this is important because of how obesity is traditionally characterized. Appearances aside, if you look at the first photograph that shows the muscle and the fat tissue, a pound of fat and a pound of muscle weigh the same, but the fat occupies a much larger volume. And remember, the muscle's intention is to take sugar and do work, where the fat's intention is to hang on to whatever it can so that it can be released on a rainy day, no matter how much you get.
Siesta.
Yes. Meanwhile, those fat cells are not just sitting there as a bank account waiting for you to withdraw. They're metabolically active. And their activity can promote the inflammation that we were talking about that can irritate your blood vessels and lead to all sorts of catastrophic outcomes. So, over time, actuarials, the people who write your insurance policies, are looking for ways to identify which people are high risk and which are low risk so they can adjust the cost of your insurance. And one person said, well, maybe a person's height to weight ratio has some bearing on their opportunity to survive. So this gentleman comes up with the body mass index. Okay, mathematically based is basically your weight divided by the square of your height times your height. And he actually came up with some parameters or some ranges of those calculations to decide who's a greater risk or not. So if you look on the lower left portion of the slide, we see that underweight is characterized as a body mass index of less than 18.5. Normal is regarded as body mass index between 18.5 and 24.9. Overweight, 25 to 29.9 and 30 or more as obese. What do you think is the problem with this?
I'm thinking football players.
Okay. Tell me about football players.
So I'm thinking about their body composition.
Okay.
And the fact that they have a lot of muscle, which is very heavy and dense. And so their weight is high, but their percent of body fat is low.
100%. Absolutely. I also use the example of sumo wrestlers sometimes.
Oh, that's
See, nurses.
Yeah.
300, 400 pounds. Podcast piece because his body mass index is 50. But this person, in order to be a successful sumo wrestler, is training 12 to 18 hours a day. That got massive amounts of muscle. So the ratio of muscle to fat is very high.
Right.
And so these people would not be, although they may be classified as obese according to the body mass index, their ratio of muscle to fat is much more what we prefer to see. So science has, again, come to the rescue, and we have a different way of evaluating a person's risk of obesity. It's called impedance plethysmography. In some cases, you can use electricity, and you can go down to one of the commercial neighborhood gyms. They tend to have these devices. You can stand on them in your bare feet and put your hands on the paddles, stand on and it'll send an unharmful electrical current through your body. The current travels at a different rate through fatty tissues as opposed to more water-based tissues, which include muscle, bone, and everything else. And by measuring the rate of the current's transmission and the amount of current that's transferred, you can determine a person's body fat mass percentage. This is not a perfect science. Okay. It's still evolving. But the beauty of it is that given the same machine for the same individual on the same day, you can actually identify trends. So I'm not just saying, oh, this person looks heavy or they measure heavy based on the body mass index. In fact, this person maybe has less fat than I would expect or maybe more fat. So now the American Council on Exercise has come up with a different table. That table shows you the characterizations of fat percentage on the right side of this slide. And it actually compares them for women who would be in the first column that you see, and for men whose allowable body fat percentages are a little bit less than women on the right side of this. But the reason I present this to you is that the body mass index still has a role to play. If I determine that an individual shows me a body mass index of 25 or more, which is overweight, and they happen not to be a football player or a sumo wrestler or a track athlete, then I want to be a little bit more concerned. There are lab tests that I can do, blood chemistry, liver panel, but I can also look at the body fat impedance, which is a little bit more expensive, less convenient, but now I'm justified as looking at this person's actual measured body fat percentage and saying, okay, this is a person that we need to pay more attention to. So the body mass index as a screening tool, yes, it does have a role, even though we understand its limitations. But in order to be economical, we don't really want to do the more extensive workup on people who screen okay. And it's also important to remember that it's possible to be underweight. That's not a key focus of our conversation, but I'm going to talk about that in terms of the slide with football players. The young lady holding the skateboard is apparently not obese, but she got an issue. Even though she's holding the skateboard, she figures that her appearance is so thin and apparently healthy that she doesn't feel that she needs to engage in a lot of exercise. Right. She still eats a very casual recreational diet, lots of chips. It doesn't show on her, but this is an individual who doesn't work out and whose body fat percentage is much greater than her muscle percentage. So in fact, according to the American Council on Exercise, this person would be classified as obese.
You can have unhealthy, skinny people. Isn't that, an oxymoron? But again, it goes back to your body's composition.
Yes. And so this is all important because it has sociological implications. Again, we don't want to attack folks for having a certain appearance, but we do want people to minimize risk and be healthy. Right. You can come in any shape or size and have that risk.
Absolutely.
So, body fat percentage, muscle burns sugar to do work. Good. In health, your insulin works and it drives the sugar into the tissues so they can do the work. The tissues also can fight inflammation when your body's sugar levels are appropriate and they can fight infection. In obesity, it's just the opposite. Fat percentage is too high. Insulin doesn't work as well, but you could resist it to it. And the inflammation is difficult to control because your fat cells are actually contributing to very high levels of inflammation because they're metabolically active. And this can interfere with your ability to fight infection as well. They can cause other harms.
Right.
And so, yes, diabetes and obesity together can lead to an amputation or heart attack or kidney failure and dialysis. So we want to address both. Why is it so difficult to prevent obesity and diabetes? Remember, we're not blaming anybody. This is an element of survival that happens to be disadvantageous today.
Right.
Conceptually, if you went back 100,000 years, nobody's planting a garden. We're not going to the grocery store. We're out hunting or we're gathering, and we don't know where our next meal is coming from. So the body naturally says, in order for me to survive, I want to hang on to every calorie that I can to release it on a rainy day. 100,000 years. It's only been in the past 10,000 years that we've been able to predict where our food is coming from, because that's about the time when we started farming. Okay, well, now we can predict food and we can get it whenever we want, right? And not exactly. You kind of have to work for it.
Right.
So even though you've got predictable food, you've got to burn those calories in order to eat what you get.
Right.
So we're still protected. It's only been in the past 100 years or so that I can count on food coming from California to Mississippi on a train, or coming to the United States from Peru on an airplane or a boat.
Right.
It's also even more recent, maybe within the past 20 years, 30 years, where I can just, sit and watch TV, reach over to the refrigerator, grab soda, grab a bag of chips or some dessert, and really don't have to work. And it's a mindless exercise. Remember, there's comfort eating. My body is driven to want to get calories and to hang on to them. And I don't have to work for them. So no wonder since 1990 has the global obesity rate increased. If we understand what's driving the body, then we can actually help the body move to a more healthy situation.
As a global society, and I don't know if you know this or not, but I'm wondering how the U.S. compares to other nations around the globe with regard to obesity. Are we among the most? Are we the most obese? I hope not, but I'm looking at your expression and I'm thinking,
There's an organization called OECD, I believe it is, Organization of Economic something.
OECD?
OECD, yes. So anyway, they rate international standards in terms of health, economy, and everything else. And it turns out that the United States is probably at the pinnacle of obesity rates, high obesity rates among the developed nations. We're right up there. And in fact, if you think Mississippi is near the top within the United States, then that suggests that Mississippi may have one of the highest obesity rates on the planet.
Oh my gosh.
Now, people who live in the South Pacific actually kind of exceed that, make their population more than 50%. But that's a relatively small population with a limited economy. Yeah, the United States has very distressing ratings in terms of the obesity scale.
So if we think about that statistic then, and we're looking at the developed nations and we're looking post-COVID at longevity, and in the United States, we still haven't recovered. Our average longevity is about where it was. It hasn't continued to increase like other industrialized nations.
I would
kind of dipped and then
definitely dipped for obvious reasons and fair reasons. But we were still laggards compared to some countries who actually have different societal approaches to healthcare, if you will. And it's not to say that the United States is bad. We're very good at some things. In fact, in discoveries and new technologies, we're very much at the top. But in terms of making that available to the full population, you'll find that there's some areas that are not only are they nutrition insecure, they can't get access to good, healthy foods, which is an important component of preventing diabetes and obesity. No matter what medicine I give you, if your nutrition is bad, the medicine won't work as well as it should. So that's fundamental. So we know that's an issue. But we also know that access to healthcare professionals is also disparate regionally. Some places have very high access to healthcare professionals. Some people have to drive tens to hundreds of miles to get to them and very inconvenient. So that difference in distribution across the country also makes a difference as well.
We talked about that unfair distribution, in our second master class when you looked at rural health and the infrastructure.
Yes. And I think that's one reason the class is so important, because the likelihood of that being neutralized or standardized in terms of access is actually quite limited right now. But by the end of this course, the entire masterclass course, you'll find out that there are a lot of things you can do yourself to prevent or minimize the frequency with which you need to see a healthcare person. That conversation is still important, but if you do things that you know will minimize your risk, then you can avoid a lot of these problems without ever having to go to them.
And we're talking about evidence-based support also in some of the other classes in particular. So getting the information, making the decision and commitment that we want to make some change, and then having access to evidence-based solutions and support groups is really important.
Absolutely.
Yeah, it makes a difference.
Well, we're getting close to our end, so I want to remind you, first of all, that to this point, we've told you that it is within your power to reduce your risk of obesity and diabetes. And if you take care of that for you, your family, and your community, a lot of these other complications that we'll be talking about or the treatments needed will not be necessary. So please, the more you can do on the front end, the happier you'll be on the back end. And by the way, if you look at the slide here, notice that diabetes status and coexisting conditions or risk include having all your natural teeth extracted. spend a long time talking about dentition, which people often take for granted. That is a vital component of maintaining your metabolic health. Okay, why is it so difficult to treat obesity and diabetes? We talked about habits and tastes. We talked about food technologies, which is now very convenient and frequently highly concentrated in high energy sugar. We also talked about the new fourth service economy. Remember, first, we were hunter-gatherers. Whatever you find, if you're lucky, you get it, and it's just as likely to get you. Then we talked about farming, which is great. We didn't spend so much time talking about industry, but that's another heavy labor type of thing. So the sugar in your bread, I work on the assembly line, perhaps, physically taxing. These days, we're very heavily into service. Okay, you go to the restaurant, you get served, somebody takes your order, or maybe you're managing care on the telephone, or maybe you're sitting at a desk filling out papers. That requires a lot of intellectual activity, but it's not as stressful, taxing on your muscles, so the muscles are not burning that sugar. That societal change, we suspect, predisposes us to inefficient usage of calories so that we get more calories than we can burn. There are some special situations, well, I'll just mention very briefly, polycystic ovarian disease, which has a component of obesity, but it's an endocrinology disorder. Endocrinologists and obstetricians and family medicine are among the people who can help you manage this disorder if it's recognized. By the way, the GLP-1 medications that we talked about earlier, and again, not giving you a brand name, but everybody will recognize it, like Ozempic, Wegovy, Mounjaro, stuff like that. By helping you improve your blood sugar control and your weight, can actually improve your polycystic ovarian disease status as well. That's not proven yet, but studies suggest that that will be a good component to use, medication to use in the future. Then if you have low thyroid, low growth hormone, low testosterone, or high cortisol, those are all predisposing factors to developing obesity. And if it extends far enough, you can get diabetes. These are all issues which, if detected, can be managed well by an endocrinologist in concert with other physicians. So just to be aware, you've heard those words in case your obesity and diabetes happen to be atypical.
Healthcare is a team sport.
Glad you said that. I'm looking forward to that Slack because it's coming up. What are some ways to manage obesity and diabetes? Calorie management. So first of all, lifestyle change. But medication, like those GLP-1s that we talked about, part of what they do is decrease the number of calories you eat. Beware with those medications of nausea, vomiting, loose stool, vitamin deficiency, anxiety, and other issues. The anxiety being because everybody goes to dinner, you can't eat what everybody else is eating because you don't have an appetite. So just be aware that those things can happen. Your appearance can change. That may make you nervous too. So as good as the medications are, they come with risks. Just be aware of them and they can be managed. Insulin boosters. Those are some of the pills we've talked about in the past, which makes your body produce more insulin to help try to overcome insulin resistance. They're in multiple generations and they're okay, but we try to limit the maximum dosage of certain types of medications because there may be better ways to manage your hyperglycemia than with those. Then similarly with insulin, if you actually need to take insulin in order to manage your sugar levels, we also want to be very careful with that, especially since insulin may actually promote weight gain as well and then lead to a vicious cycle. So what in the case of insulin boosters and insulin, watch out for low blood sugar. Procedures. Everybody's heard perhaps of weight loss surgery, also called bariatric surgery or weight management surgery. Can be very effective provided the benefits of the surgery have a chance to kick in. It may take weeks to perhaps months for your body to adapt to your new gastrointestinal structure. And that may be difficult for you psychologically because your mindset is still, I want to eat what I was eating before, where your body says, I can't do this anymore. So in those cases, nausea, vomiting, loose stool, vitamin deficiency, anxiety, bleeding, wound issues, and obstruction. Suppose an individual has a gastric reduction surgery or an intestinal reduction or alteration surgery, and the foods that they used to eat before are not appropriate for that more constricted space and they get a blockage. That is a risk. When a person is preparing to undergo these types of procedures, usually they will have extensive conversations with the dietitian, with the endocrinologist, with the surgeon, with the internist, so they can understand that their mental preparedness for this operation, and their ability to follow the instructions is critical to the operation's success. Some people are finding that adding a GLP-1 around the time that you're getting ready for the operation makes it easier for patients, because the GLP-1 actually has a central nervous system action that decreases your desire to eat, as well as the intestinal action. So maybe that medicine will give you a chance for your body to adapt to the new physical structure that you have. And in the long run, you won't need that medicine anymore because your body can take care of it. But again, this is all under research right now.
So what's sad is when we see people and individuals who go through the surgical procedure and they do really well, but there hasn't been a change. Sometimes it's mental. You mentioned the different health professionals. To have a mental health counselor on that team, again, to help someone work through the psychological adjustment to a new body image, the physical appearance, the way that relationships can change. There are just so many factors. So when you see someone who has been successful, but then their habits return, the previous habits that created the problem in the first place. It's just really unfortunate.
So that type of support is absolutely critical. And I think the public probably doesn't appreciate that to the extent that they really need to. Yeah.
Certainly when we think about some of the television shows that feature patients who are undergoing bariatric procedures, we don't see that part of behind the scenes. And I think that is really a terrible omission. Because the educational value would be immense.
We did talk about special endocrinology situations, and I've just listed, some options. We talked about GLP-1 likelihood of benefit for polycystic ovarian disease. We'll see. Thyroid hormone. All the other situations are corrected by specific therapy by the endocrinologist, just so you know. If you happen to fall into one of those unusual categories, then yes, you need to see the healthcare professional. How do you protect yourself? 3 lifestyle ways, which we strongly suggest. I'll just say the negative one first because it's so simple. Don't use substances. Tobacco, well, I smoke because it helps me lose weight. Yeah, but it's got other health problems. So no. Tobacco, avoid alcohol as well, and then other substances that may impair your judgment, your willpower, and your ability to make good decisions. Second, the positive things that you can do. Get enough sleep, take care of your teeth, get good nutrition, pursue appropriate fitness, including strength training, not just walking, which is good, but get stronger so your muscles can make good use of that sugar.
Good for your bones too. And grooming in particular when we think about, aging,
Oh yeah. Then mental health. Just finished talking about that under the context of the weight surgery, but it applies to every aspect of your life.
Sure does.
Yes. And having those family meals around the table can help children identify good coping mechanisms for life's routine problems. And that's an important opportunity. Then education. There's a program called the Diabetes Prevention Program. It's a research-validated education program offered or sponsored by the Centers for Disease Control, which actually teaches you in a systematic way a lot of the things we've been talking about today and helps you adapt these principles to your own life situation. And if you, by chance, happen to get diabetes, there's the Diabetes Self-Management Education Program, which again helps you identify the best ways to leverage your lifestyle, medications, and other technology in order to have blood sugar controlled as well as possible. In the case of the Diabetes Self-Management Education Program, we mentioned continuous glucose monitor before. Again, ordinarily, your body doesn't bother you. Your pancreas releases the insulin based on its measurements of your sugar. But once you develop diabetes, either from resistance or from not having insulin produced at all, your body has abdicated that responsibility. It says, I really need you to know where your blood sugars are so that you can give me the right treatment so we can keep these sugars under control. Your body needs for you to do that. And a continuous glucose monitor can help you do that well. So treatment, shared decision-making, glucose monitor, medications that we talked about, and surgical procedures if necessary and possible. That's for the individual. What can I do for my family? Shared meal times, model positive and negative behaviors appropriately, and talk to your family about risks. You know, if you know that there's a family history of diabetes or obesity, or if there's a community risk, talk to your kids about it, you know, just to make sure that they're educated and they understand how to make good decisions to keep themselves healthy. Then for my community, I go out with students frequently, or health profession students, to do health fairs. This is an opportunity for you to get free information about your health status, or maybe the status of your community. You know, we don't live in isolation. Generally, we have friends and neighbors. And if we have new information that might be helpful to them, why not share it?
Put it on the grapevine along with the other kinds of stories that you're sharing, right?
Absolutely. And support people who are advocates for finding solutions to obesity and diabetes. Maybe they are fundraising and you can help with that, or maybe you want to join an agency. It'll be educational for you and be helpful for the community and the nation. Then research. We may come to you as we started out at the very beginning. I've got a new medication. Do you want me to test this, to give this to you now before it's been tested? Or do you want to know that this medication has been helpful and positive and well tolerated in your community?
Right.
We depend on the public to come and generously volunteer for safe participation in our research. So don't be afraid. Don't be afraid. We have your best interest at heart. By law, we have your best interest.
Absolutely. And it's a way to give back to the generations that precede you.
Yes.
To your children and grandchildren, and make a difference.
Absolutely. And again, your privacy is protected by law. Your safety is protected by law, but the contribution you make is invaluable.
Absolutely.
You can't be replicated. So diabetes prevention program, we're getting exercise. We have great nutrition. We have sleep. We're talking about family meals and how important those are.
24th, you got it.
So on June 12th, front page, New York Times, more proof that individual behaviors can affect the family and community. In some Ozempic, that's their word, not mine, households, the weight loss is contagious. One person's taking the Ozempic, the entire family loses weight. But you don't need to have that medicine available in order for your change in behavior to have a positive impact on your family. But it happens for the reasons that we've just been discussing. Having your family at the table, being able to talk and share problems and diet is worth its weight in gold. Mississippi, as challenged as we are, Mississippi has made massive strides.
Mississippi is knocking it out of the park. Education, literacy.
Yes.
Disease management.
Yes. I'm very pleased to share 3 initiatives. So I am one of the co-chairs for the state Obesity and Diabetes Task Force. We came up with 3 suggestions what the state has decided to include in its 2022 State Health Improvement Plan, which you're involved in. The first one is called the Power-Ups for Youth. Basically, it's the opportunity to talk to children through grade school and high school once or twice a year to have a conversation about 5 items: sleep, your teeth, nutrition, fitness, and mental health. In those conversations, we're not telling the kids what to do, but we're telling the kids, asking the kids what they think about these issues. They're either going to encounter them or ignore them, or they're going to encounter them and pay attention to them. But as the children are talking about these things, now they realize that, oh, sleep really is a thing. I wonder why we have to sleep. They'll think about it. And hopefully, over the years, as they continue to have these conversations, they will either investigate these issues on their own, or they'll pay more attention to information that comes, or they'll at least recognize that somehow, in relation to the activities in their life, maybe they like to pursue sports, they find they perform better after a good night's sleep. They will understand that these are important considerations. We're not giving them instructions, but we're saying, think about these things because they may be important to you. We know in medicine that they are important, but it's really nice when you come to that conclusion on your own.
Right. That's when you internalize the information. It becomes your own, right? It's not something that you're reading because it's outside, but you adopt it and it becomes part of you.
Absolutely. Right? Absolutely. Yeah. So we're very excited about that. The second piece that we're really thrilled about, and we really thank the Public Health Institute for helping us with this, is a nutrition map that is intended to work in real time. Mississippi has been identified as one of the most nutrition insecure states in the country. And part of the reason is that the number of family farms has progressively dwindled. And as we mentioned before, people don't necessarily make their living working on the farm anymore. Mm-hmm. But you have to get your nutrition somewhere. You may not have access to a very well-stocked grocery store.
Right.
You may have to travel dozens to hundreds of miles to get there, and it becomes very inconvenient and very expensive sometimes. Mm-hmm. So in order to make this as convenient as possible for the public, we have this nutrition map, which you can actually put your zip code into and find in concentric circles, the closest grocery store at 5 miles or 10 miles or 50 miles. Mm-hmm. The beauty of this is not only that we have identified grocery stores and other sources of nutrition, roadside stands, people accept women's WIC.
Run infants and children.
Run infants and children types of funds, those types of things. And we're also pleased to make this not only available to the community and to the vendors so they can find opportunities to locate in places that are underserved, but also to the legislature as asked, where can we get this information in one place? There are like 20 different databases that we had to coordinate with who have graciously agreed to feed information on a regular basis so we can keep this up to date. But now we understand where the risks are, how to access the food conveniently as possible, and how to resolve the issue if we're a vendor or we're for a government. So we're thrilled with that.
Wow. I'm going to come back and pick your brain on this one because I have a colleague in nutrition. She and I have been actually doing this on a smaller scale, just working at Alachua County because we have such tremendous food insecurity.
Yes.
In the county that houses the University of Florida. And so the fact that you have a mechanism, you have discovered how to do that. We have all of the names, we have all their addresses, but putting it together as a map. So
we'd be thrilled to talk to you. We're very excited about it.
I think this is something every community can benefit from, really.
Absolutely.
Yeah.
The third piece, another Mississippi initiative. Remember we talked about the diabetes prevention program? Mm-hmm. The challenge with the program is that it has been difficult to access the program in many neighborhoods. You have certain centers where the program is actually delivered and managed, but it's not as convenient to get to. Mm-hmm. So now we have set up a mechanism by which, and again, this is in preliminary stages. It's not operational. So you may call and say, I want to sign up for that program. It's not there yet, but we understand that it can work. And so we're trying to go to the next level on that. But the long story short, there's actually a platform, if you're interested, that you can actually submit your name to and say, I'd like to be a diabetes prevention program coach. Mm-hmm. They can assist you with training. They can assist you with finding participants for the classes in your neighborhood. And there's potential to get paid.
Oh, that's great.
So again, this is early days, not available yet, but we're absolutely working on it. And we're thrilled with this as a potential solution as well. Mm-hmm. Then on top of all that, the state of Mississippi understands it's still important to have access to health professionals, even in the most underserved areas. So we're building a community health workers program. Now, these individuals have to deal with all aspects of healthcare, not just diabetes and obesity. So it's a heavy lift, but being able to get these folks on the road to your community so you can ask the questions and they can investigate and help you find resources and information and solutions. Huge.
Right. We're doing that in my community too, in Florida. So we have, Alachua County has a community health worker program.
Wonderful.
And so it's about 3 years old. We started with ARPA funds, but, it's a program that meets needs.
Oh, yeah.
And it's surprising how many other, organizations in my community have navigator type, individuals who will help connect people to resources. Sure. It seems like a no-brainer to me. Why don't we use more paraprofessionals to help people navigate life and navigate their health and other areas? But I'm just glad that these ideas are catching on, right? And they demonstrate economic benefit.
Oh yeah, they make a difference, and they can actually be inspirational. Mm-hmm. You have a young child who's trying to decide what career they want to follow. This person has made a difference in my life.
Right.
They may never have a chance to see a physician regularly or a nurse practitioner or a dietitian or social worker, but these folks actually being out in the community and roaming can make a difference in more ways than just direct health.
Absolutely.
So this final slide kind of brings it all together. We talk about the lifestyle changes that you can do before an issue is diagnosed and continue through with them after it's diagnosed and share this information with your family to protect them if possible, from getting the problem in the first place, but certainly making it better if you do have the issue. Then if a problem does develop, please, visit a healthcare professional. They're not there just to tell you what to do, but they're there to help you figure out what to do and help you do it. It's also important, to the extent that you feel comfortable, understand the risks in your community. And if there are things you can help to lower that risk, it reflects back to you and the family in a positive way.
Right.
Those conversations are good. You may need medication. You may even need insulin. So whatever it takes to get that sugar under control so you can avoid those complications, maybe an operation. But remember, any of these things require that comprehensive approach with multiple medical experts, mental health, the traditional diagnostic medication solutions, maybe physical therapy, maybe sports medicine, depending on where you are. But try not to, it's important to get the maximum input that you can if you can do it. Then what we're trying to do with our students is make sure that they understand at the earliest level possible how to engage the population and help coordinate these comprehensive shared decision-making approaches to disease. The students absolutely love getting out and talking to the community and making sense of the scientific principles they learn in the context of real life for people.
Right.
Then finally, why does Mississippi or Florida or the United States care about this? Medicine and healthcare are expensive. They're very expensive. And money that I don't have to spend fixing problems, I can actually use to make life better in other ways and charge you fewer taxes.
Oh my goodness. It just becomes a positive upward spiral, right? Instead of downward.
Absolutely.
Such a nice change, right?
100%.
Well, you've given us a lot of clinical information, but you've also given much practical information, for which I'm grateful. Because even though this series is focusing on the needs of health professionals as well as students, at the same time, we don't know who those who participate in the master classes will come into contact with and share information. I heard someone speaking and, they said something that I've heard before, but it just kind of, came together in a different way for me. So our hope is that some of those who don't know that they are living with diabetes will be able to recognize some of the signs, maybe some of the symptoms, and at least go visit with a healthcare professional and have an assessment.
Sure. Or if they know there's a family risk, they can take steps to make sure it doesn't happen in the first place.
I think knowing your family history is so important. And I used to teach a course, Women's Health and Wellbeing. And one of the assignments was a semester-long assignment to learn about your family's medical history. And it was surprising how many students would discover that there were familial cancers, knowing not only your parents, grandparents, but if you can dig back a little further.
Sure.
And you can do that with a lot of online tools.
Yeah.
So valuable information.
And people in Mississippi in particular shouldn't forget that half the population is at risk of obesity. That's 1.5 million people.
A lot of people.
So now that you know the risk, you can do something about it.
So everybody, there you have it. Lifestyle Medicine 101 in a package. Everything that you need to do to stay healthy and well, and pursue your optimal health. So following this presentation, we know that Masterclass number 9 is going to take a look at tobacco cessation, and tobacco was something that you mentioned. So everybody, please come back and join us for the 9th Masterclass. Dr. Jonathan Hansis, who's an assistant professor in the School of Population Health and the Cancer Center and Research Institute at Ole Miss University, is going to be our speaker, and he's going to give us not only information about tobacco, but he's going to give us a lot of prevention tips and resources that we can use in our day-to-day lives. So at this point, we have nothing more, and class is dismissed.